Okay. Lovely, great. Good morning or good afternoon to all of you. My name is Sabah Balasubramanian. I'm an endocrine surgeon based in Sheffield, UK. We had a really interesting lecture from Dr. Gonzalez. I'd invite him to join our panel if he could to answer some questions, to give a perspective from South America. I will begin with no further ado. I'm aware we're running late, so we'll try and make up some time to see if we can finish this part of the program 5 or 10 minutes early. So can I ask my panelists to introduce themselves, please? We'll start with people on my screen. We already heard from Dr. Gonzalez. He's welcome to join us. We'll then go on to Dr. Siddiq. If you could tell us what your specialty is, where you work, and if there's anything particularly you're interested in or focused on in relation to thyroid cancer. Thank you.
Hi, I'm Samir Siddiq. I'm a head and neck surgeon based in University Hospitals Birmingham in the UK. My practice covers head and neck malignancy and thyroid and minimally invasive robotic surgery.
Thank you. I've got Mr. Nagla on my screen next.
Yeah, hi, I'm Sidney Nagla. I'm the ENT head, neck, thyroid and parathyroid surgeons in Royal Berkshire, Reading. Interested in all things thyroid, parathyroid, specifically transoral scarless thyroid, parathyroid surgery, and also AI in diagnosing thyroid nodules.
Okay, Dr. Venkatesh.
Hi, good evening from India. I'm Dr. Venkatesh, from a surgical oncologist from Adyar Cancer Institute. I finished my surgical oncology in 2011, and from 2014, I practiced only head and neck oncology. My area of interest is CO2 laser microlaser surgeries, transoral robotic surgeries, and thyroid surgery.
Thank you. Dr. Kyung Tae, I don't know if he's here.
Yes, good afternoon. I'm Kyung Tae. Yeah, I'm here. Yeah, I'm Kyung Tae from Hanang University, Seoul, Korea. I'm actually the ENT head and neck surgeons. It's very nice to join this conference. I'm also serving as the director of Asia Pacific Society of Thyroid Surgery. Thank you.
Lovely. And Dai Kim is here. Do we know Jay?
Can't see him.
Okay, fine. Let's crack on. Right. So I'll start off with the initial presentation of a patient, and then I'll go through the panelists if that's okay. And obviously, if you have a comment, you just put your hand up or pitch in. And Jay, please feel free to interrupt maybe after each slide. If there are questions from the audience, we might as well take it as we go along. So we've got a 60-year-old lady who's had breast cancer diagnosis and treatment recently. She undergoes a PET scan, which shows a focal area of uptake in the right thyroid lobe. So I guess you would all come across this kind of presentation of incidental findings in the thyroid. So you see her in the clinic, there's a 2-centimeter nodule on the right side. There's no palpable lymphadenopathy. She's got a normal voice. Your voice assessment is okay. You might have done a laryngoscopy. That's okay. TSH is fine. And her primary care practitioner has already requested an ultrasound scan that showed a hyperechoic hypervascular lesion with a smooth outline, with no microcalcifications, no lymphadenopathy. She's well, her breast cancer treatment is completed, and there's no history of thyroid disease. There's no family history of thyroid cancer. There's no prior exposure to radiotherapy to the neck area, no prior neck surgery. So my question, can I start with you, Sid, is what further information do you need? Or do you need any information?
Yes, quite a bit of. So you've got a normal thyroid function test there. I would want to get them. So first of all, a PET scan avid thyroid nodule, we know it's about 33 to 35% risk of malignancy. Somebody like this, it's not an uncommon scenario. And actually, we do see patients with previous other cancers in other sites of the body. And I know this patient is going to be naturally anxious because of having a potential another cancer as well as a breast cancer. It's essentially, I would want to know the ultrasound grading. I know you mentioned a few features there. I was just looking through I'm not a radiologist, but I would want to know the grading. We use ACR Thyroids in Reading. I know that's, and a few other centres in the UK do that, and that's American based. But obviously the kind of routine practice is U classification. So I think I'd want to know the TR grading, and also whether we need to do an FNA based on that.
Thank you. Professor Kuhn, can I ask your perspective? Is there anything you would do? Specifically, I'm thinking about calcitonin levels. I know in Europe, many centers would do routine calcitonin assessments in patients with thyroid nodules. And the other question I have in my mind is, would you routinely do or check for thyroid peroxidase antibody levels?
Yeah, in Korea, we don't test routinely the calcitonin level in the polythyroid nodule. If there are suspicious findings in cytology, we may add this calcitonin test. And so TG is not routinely recommended, but in most the Korean surgeons that do the test for the TG level or TSH level. Also, many surgeons also prefer the anti-TG antibody levels.
Okay. Okay, that's great. Yeah, I mean, I agree. We don't do TPO. Sorry, we don't do routine calcitonin assessments in the UK. Some surgeons add a thyroid peroxidase antibody level to the TSH with the intention that it might be useful when it comes to interpreting the cytology. If the thyroid peroxidase antibody is very high, or if the TSH is high, then obviously the patient has an element of thyroiditis, and that would affect the interpretation of cytology. So, Maya, can I come to you next and ask what would you do next with this picture?
I think crucially it's understanding the sonographic features, and if they've been done by a specialist head and neck radiologist. We used a U1 to 5 grading, and as we know, there's only one feature here, hypoechoic. You've mentioned it's a hypervascular lesion, but we know in thyroiditis that can be hypervascular also. So I think that constellation of features needs to be looked at more carefully to identify if this needs a fine needle aspirate. Depending on that result, obviously, then we need to understand if, again, based on Thy1 to 5 cytology criteria, the management thereafter.
Lovely, thank you very much. Right, so I'll get straight to the point with the ultrasound classification that Sid mentioned. So we have a BTA-U stage 4 that translates in this lady to an ACR Thyroids TR4. So that's the ultrasound that ultrasound categorization that leads on to an ultrasound guided cytology. And you got a cytology report of Bethesda 3. In the UK, we use the Royal College of Pathologists Thai classification, so that would be 3A in our system. So could I ask Dr. Venkatesh, what classification system do you use in India, and is there a reason, or is this what your radiologists use?
Good evening. We use the Bethesda system of classification for reporting cytology. This is what pathologists are more comfortable with. But for ultrasound, we use the Thyroids system.
Lovely.
And in this patient, I would like to add one more thing. Since it's a PET detected nodule, the incidence of malignancy is little higher when compared to the other incidental it's around 30%. And I will also, as a surgical oncologist, I would like to add that the patient is already having a breast cancer. So I saw that she was an early breast cancer, but in the perspective, one should also keep in mind that the survival of the breast cancer is important, in the sense that if she's a long survivor, then it is worthwhile to evaluate and treat her further. If the survival itself is bad, then there is no point in evaluating the thyroid nodule further.
Yeah, Yeah, no, that's a really good point. And that's why I specifically said early breast cancer, just implying that the prognosis is pretty good in the 60-year-old. So thank you. Right. So what would you want to do next? I'll stay with you. That's okay.
I would like to do an ultrasound guided FNAC of the nodule.
So you've got a Bethesda 3. So you're saying you would want to repeat ultrasound guided FNAC, is it?
No. Sorry, I didn't see it. It is Bethesda 3 and it's around 2 centimeter, I suppose. So I would, since it's a PET detected nodule, the risk is little higher. I will give the option of a surgical option for this patient.
Okay. Dr. Gonzalez, yeah, I was going to come to you. Thank you very much. Please tell us what you would do.
Yeah, maybe I would ask the cytopathologist if it is evident that the patient has nuclear atypia or not. That's a very, very key element in order to determine if this Bethesda 3 is a Bethesda 3 of high risk or Bethesda 3 more in the formerly called FLUS group. Because we differentiating the architectural atypia from the nuclear atypia is something that is very helpful. And if you add that to ACR TRS 4, and then you add that to I'm not sure what the SUV for the PET was, because that also has just the fact that it's present is a higher risk, but it's not the same to have an SUV of 2, an SUV of 20. So that's also something to keep in mind. But overall, I tend to agree. If there's nuclear atypia, SUV positive, the ultrasound is uncomfortable, maybe a lobectomy would be a good option.
Lovely, thank you very much. So yeah, it was quite bright. I don't remember the SUV value, and there was nuclear atypia. So we elected to repeat the biopsy. So we did a repeat cytology, and you've got Bethesda 5, RCP Thai 5, Bethesda 6, papillary thyroid cancer. So as a straightforward diagnosis, thank goodness. So then the question would be, would you consider any non-surgical management in this lady? I think we've already briefly touched upon that. But if I can stay with you, Dr. Gonzalez, is that an option in your practice at all?
This is a 2 centimeter nodule?
This is a 2 centimeter nodule, yeah.
Yeah, we haven't reached that level of comfort yet. My threshold is 1.5. If it's intrathyroidal nodule, no lymphadenopathy, no nodules on the other side, the patient doesn't want to have any more treatment, I would be willing to offer active surveillance. Alternatively, if again it's a some circumscribed nodule, the lobectomy would be our preference in surgery.
Thank you. Can I go to Professor Kyung? Would you consider conservative management? And the other question would be, do you or anyone else on the panel have experience with non-surgical ablational treatments for thyroid cancer as opposed to a benign nodule?
Yes, before the management, I'd like to comment about the lipid cytology. And for the class lipid cytology for the Bethesda class category 3 and 4, I prefer the corneal biopsy. Just repeat the cytology. Corneal biopsy shows relatively slightly better sensitivity. Also, it's helpful to avoid some inadequate samples. So I prefer corneal biopsy for the lipid cytology. And this patient, the lipid cytology is papillary cancers and 2 centimeters. And actually, she needs surgeries for the treatments and also the final pathway, final diagnosis. But we need to discuss with the patients. We need to consider about 2 centimeters. Okay, we might can do the patient put on the active surveillance trial, but we need to be very careful, 2 centimeters. But I think is now we have some evidence, and not evidence, not reported, but in Korea we included up to 2 centimeters for the active surveillance. So we need more data for those tumors. And the 2 centimeters tumors, we may try the radio frequency ablation. But this 2 centimeters is too big for the radio frequency ablation. In Korea, we tried for the small size micropathologic cancer, and some of the data show that it's promising results. The tumors, micro cancer located in the centers of the thyroid glands, not too close to recurrent nerve and trachea, we can try it. And the 5 years oncological outcome is promising.
Lovely, thank you very much. So, would you want any further investigations if a decision has been made for surgery? I'm thinking scans, blood tests we've covered. So is there anything else you would want, or are you proceeding to an operation? I'll stick with you, Prosecutor.
We need to discuss about how to manage, how to surgery if she want to do that. So,
okay.
And what stage of this patient?
They're 60 years old.
60 years, a little bit too old, but in also this 60 woman is also woman, so they usually in Korean women prefer the scarlet surgery. So we need to discuss about the scarlet surgery using remote access thyroidectomy.
Okay, lovely. Thank you very much. So just to give a UK perspective, we wouldn't do non-surgical ablative therapies for malignancy. With the rabbit trial that's just started is looking at radiofrequency ablation in benign nodules. And with regards to surveillance, I personally would be reluctant, like it has been mentioned, for nodules of this size, 2 centimeters, in an otherwise well patient. But that's certainly something to think about. I came across this paper recently, and I thought I'd just put this up. I thought this was a really good review paper on the conservative management of low-risk papillary thyroid cancer. The good thing about this paper is that it pulls together the results of a number of trials. As you can see on the screen, there are quite a few trials now out there where patients with thyroid cancer have been surveyed without surgery, and you can see that reassuringly the quite significant follow-up periods. The deaths are none, and no patient had distant metastasis. A few patients have some progression of the tumor, and the occasional patient has got lymph node metastases that have appeared during follow-up. So that's certainly something to keep in mind when you're counseling patients. Because we do have the occasional patient that comes and asks, can I just leave it be? I'm not symptomatic. This got picked up incidentally, which I think is quite a reasonable question. Okay. Now, we're planning thyroid surgery. And I know Daikim isn't here, the man running the HOT trial. So I'll probably go to Sid, if that's okay, Sid. Could you take us through the discussion and the consenting process while you're considering hemi versus total thyroidectomy? What would you be inclined to suggest if the patient says, what do you think is the best option?
Sure. And I think these patients would go through locally in our Thames Valley MDT. I think that's an important factor to look at local practice. And I think that's we in Reading, we are a site for the HOT trial, so we would mention the HOT trial in the MDT and actually broach that with the patient, and our R&D department would be involved in that process and give the patient information sheet in advance. But essentially, our normal practice prior to HOT trial in Thames Valley, at least for this type of patient, would usually be to offer a hemithyroidectomy unless there's any other adverse features on imaging, or is any lymph node metastases, or is any kind of I think you mentioned the ultrasound, it was a smooth nodule. So certainly there's a lot of literature on hemi versus total. I know the HOT trials and various other trials, a randomized controlled trial. I actually, prior to this conference, I saw a systematic review and meta-analysis that was published in Amsterdam in 2020, where they looked at over 20,000 patients, 10 cohorts, observational studies, looking at Hemi versus total for a T1 to T2 and naught type of patient, and they actually had similar recurrence and 20-year survival rates in both arms. So I think that's important. But obviously, a randomized control trial would trump that type of study. So.
Thank you, Sid. So if I can come to Ms. Siddiq in terms of surgical approaches, let's keep the hemi versus total debate to one side for a moment. Assuming you're doing a hemithyroidectomy, are you offering minimally invasive approaches, or is it standard open hemithyroidectomy? Would you like to comment on that, please?
No, currently we offer the standard open approach. We haven't converted to minimally invasive approach. I think the cost effective and the benefit ratio within an NHS UK practice at the moment really limits that, although those surgeons, a few early surgeons, have adopted potentially transoral approaches, which I think potentially have probably a much greater efficacy in terms of cost anyway, going forward. But currently it'd be open for us.
Yeah, quick comment from you, Sid. You started total. Would you consider a cancer patient before I go to non-UK surgeons?
At the moment, as we're getting our learning curve up, we probably, I think 2 centimeters is a little bit on the kind of the higher side. I don't know international criteria. I know Prof. Ty will mention. I'm sure he may well offer up to 2 centimeters for a potential cancer. But certainly we've done a 12 millimeter papillary cancer that was referred from Plymouth, and that actually come back as an 8 millimeter PTC, and that was fine. But certainly from a cancer perspective for transoral, we I think 2 centimeter at present, maybe as we do more numbers, we'll be able to operate, but at present not.
Yeah. Okay. So can I ask for a brief comments from all of our non-UK speakers, Professor Kuhn?
Yes. We need to consider various options for deciding the surgical approach. But I'd like to comment about this. The transoral approach or other types of immunosuppressive approaches is feasible for this, low risk side of cancer. I reported 5 years oncological outcome after transoral lower risk thyroidectomy for papillary cancer. My data show that comparable, there is no difference between the conventional thyroidectomy and transoral lower risk thyroidectomy. The recurrence rate less than 1%. Low risk papillary cancers.
Thank you, Dr. Gonzalez.
Yeah, we routinely still offer the open approach. It's just mainly due to cost effectiveness and time of operating time, which is way lower with the traditional approach. And when you have small tumors, the incisions are 2.5 centimeters. So the patients really would have to pay a lot more to get the transoral. So our preference is mostly open.
Thank you, Dr. Venkatesh.
We also do open surgeries, but if a patient asks for it and if it's affordable, there is nothing wrong in doing a minimally invasive thyroidectomy for tumors even if it's cancer, less than 3 centimeters.
Lovely. Thank you very much. So I'm going to move on to the next slide. So I think Sid's mentioned this systematic review published 2-3 years ago that compared hemi versus total thyroidectomy for T1, T2 cancer. And the recurrence rates, as he's mentioned, were obviously the complication rates were lower hemithyroidectomy. And then Dai Kim and colleagues published another systematic review in the same year in a different journal, which showed that the recurrence rates with the hemithyroidectomy might actually be slightly higher. And I think this is a good time to mention the HOT trial, the UK multi-centered hemithyroidectomy versus total thyroidectomy trial in low-risk thyroid cancer that is currently recruiting. Right. So let's carry on. So you're doing the operation and you're doing the right side. You decided to do a total thyroidectomy. I don't know if I said that. Apologies if I haven't. So let's assume you've decided to do a total thyroidectomy because the patient wants all of it out and not want to think about recurrent cancer or keep the recurrence rate to as low a level as possible. And while you're doing the right side with intraoperative nerve monitoring, and there is a loss of signal. And you're thinking about it, and then you noted that there's one lymph node adjacent to the lower pole of the right lobe that you have seen that looks abnormal. Right, so the first question would be about loss of signal. So if you're planning a total thyroidectomy in a patient like this and you've lost signal, can I come back to you, Sid? What would be your approach? So I've got the awkward ones for you, especially, Sid.
Sure. No, that's fine. Actually, with this type of patient, I probably would actually had a pre-surgical consultation about this scenario specifically. It's only I do for Graves' disease, for example, for benign disease, and I would actually talk about whether, if there is a loss of signal, whether we'd go to the other side. I think with her, if she had a much bigger tumor, and we know she's definitely going to get radioactive iodine, etc., I'd probably counsel, even if we did have a loss of signal, we would go to the other side. But actually, in this scenario, I know there's an enlarged lymph node, but actually, my kind of gut feeling with her would probably be was actually maybe to stop unless you, and actually come back at a later date when we get the signal back. But it all depends on how confident I am with the nerve, also during the surgery, whether it's intact or whether it's bruised or that kind of thing. So I think those kind of features, if I'm confident it's intact, maybe loss of signal from neuropraxia, I'd probably call it a day actually, having had a preoperative consultation with her. And say we may well come back, especially because it's a 2 centimeter low risk cancer. Just because obviously the risk of, if you roger the other side, then she's going to end up needing a tracheostomy, which is quite a significant complication.
Yeah, so sorry, I've kept it really simple. I know that there's much more nuances to loss of signal. You talk to the anesthetist, check the relaxation, and check the vagus, see if the nerve is visually intact, and so on and so forth. And you'll give it some time. But for the purposes of this discussion, if there's loss of signal, there really isn't any need to proceed to the other side, especially if you think that there is a significant potential for nerve injury. I don't know if there's any comments from anyone else on this particular thing.
I just say it's a combination of obviously a preoperative function of larynx, normal functioning nerve, obviously what you find intraoperatively, and then obviously the real reasoning for that loss of signal, which obviously you try to assess for. But she's a low risk patient. She's 60. The impact of damage to the other side is higher when you've already lost signal on the first side. So this is somebody that if you did lose signal, I would wait and defer and come back and obviously review for recovery before addressing the other side if you need to, depend on the post-op pathology and additional information from staging.
Lovely, thank you very much. If I can stick with you and then say the signals come back, it just went for a few minutes while you're umming and ahhing about this lymph node, and then you got this lymph node, and what are you going to do? So in terms of, are you going to ask for a frozen section? Is that available? Is it straightforward to get at your place? Or are you going to do an ipsilateral neck dissection or bilateral central neck dissection?
So we don't have routine frozen section available within our unit. I would have hoped that as part of your preoperative counselling, that is part of my counselling in terms of potentially if you need to do a right-sided paratracheal dissection, I can go ahead and proceed. Ideally, you wouldn't want to be in a situation if you've done your investigation, if there'd been a significant delay to surgery, you may find yourself in a situation, but with a preoperative ultrasound, if you've really carefully assessed those central neck nodes, and if not, undertake cross-sectional imaging before you land yourself in this scenario, because there's no doubt you'll increase the potential injury to the recurrent laryngeal nerve if you haven't counselled for that patient prior to and consented them for at least an ipsilateral right paratracheal neck dissection.
Thank you. Any other comments? I mean, so preoperative ultrasound with a view to documenting or predicting central lymph node metastasis is not that good. I suspect we do occasionally come across this scenario. So any other comments from anyone else as to frozen section?
Intraoperatively, the nodes are suspicious, and there are, since this patient has only one nodule in the right lobe, and the contralateral lobe does not show any nodule, that node alone can be, there is no need to do a frozen section of the node. Just pick up the node and send it for final histopathologic examination. And I presume that the nerve, there is no loss of signal in the nerve.
Yeah,
the nerve is intact.
Yeah,
that case,
intact, signals come back. So you just take the node out along with the lobe.
That's it.
And
I'm more worried about the parathyroids than the nerve in this patient, because a complete ipsilateral paratracheal dissection can cause ischemia to the parathyroids.
Okay. Anyone would do a central neck dissection in this instance? I think Sid put your hand up.
I don't know. Venkatesh just mentioned, I think enlarged node, I think would be liver capital parathyroid, and I know Sabi use autofluorescence, and then that might be helpful in this scenario. So, but yeah.
Okay. So so there's no one that would do a central. Well, I think Ms. Siddiq suggested you might take the paratracheal lymph nodes, didn't you? Dr.
I think my point to that was preoperatively probably cancel the patient first, because obviously you can't do this without formal consent within the UK practice. The other thing is, if you cherry picking or berry picking is not an appropriate concept if you don't have frozen section, and having to return back into that compartment after you've done that or not address it potentially will result in higher risk nerve injury.
Yeah, okay. I mean, we have frozen sections, so we get a frozen section in our place. And if it was a Thyroid, then I would usually say to my patients, if there are lymph nodes, I'd do a central neck dissection, or at least an ipsilateral central neck dissection would be our policy. But I guess it's important to say here that it really depends on your local protocols, facilities for frozen section, and your experience with central neck dissection. You probably manage this on a case-by-case basis based, as has been said, about what you've consented, what you talked about with the patient before the operation. So I'm presuming there are no questions coming, Jay, so we'll carry on and we'll go on to the next slide.
Yes, please.
Okay. So I just wanted to say that prophylactic central neck dissection for patients with clinically uninvolved neck lymph nodes, ultrasound negative, is really not practiced in the UK. Now, I know that in many parts of Europe and in the Far East, prophylactic central neck dissection is practiced. I was going to ask Professor Tao about it. I don't know if he's still here. Yeah, he's here. So clearly, if you look for lymph nodes and remove all lymph nodes in the central neck in patients with papillary thyroid cancer, you're very likely to find microscopic metastasis in many patients. We know that. And therefore, you could argue, and there are lots of observational studies that have shown that you will reduce longer-term local recurrence rates, but the complication rates with regards to nerve injury and hypoparathyroidism are high. In the past, we used to do prophylactic central neck dissection for high-risk papillary thyroid cancer. We've stopped doing that. We certainly wouldn't do that for low-risk papillary thyroid cancer. Can I ask Professor Tay's opinion on this? I can't see him for some reason.
Yes, I'm here. Yes, I'm here.
Yeah, you're here. Sorry.
Yes, yes. Okay, yeah, the prophylactic central neck dissection for low-risk papillary cancer is not necessary. But in Korea and East Asian countries, usually, previously, do the prophylactic central neck dissection routinely as a kind of habitual the scenario. But nowadays, many surgeons stopped doing the prophylactic CN. It is not necessary. It's not related to the improved survival, even in decreased recurrence rate. So it relates to usually high complication rates. And there are suspicious lymph node one side during the operation by the inspection or palpation. We can do the ipsilateral side central dissection is enough. The bilateral is not necessary.
Yeah, ipsilateral central dissection. Okay. Dr. Gonzalez, can I ask you as well before we move on?
Yes, we do not perform routine prophylactic neck dissection because when you look at these studies and what they talk about recurrence, the question and the problem with these studies is that the definition of recurrence is not equal. So some will say recurrence is any finding, minimal structure finding or biochemical that would reflect a recurrence versus a clinically relevant recurrence that you will do something about it. So when you want to compare really recurrences that are clinically meaningful, that's the actual question, because you will see the ultrasound is able to see very small recurrences that have no meaning whatsoever, and you can follow them forever. And so that's why we feel that the prophylactic neck dissection data today does not support in any way and provide a clinically meaningful benefit.
Okay, thank you very much. Let's move on then. Right, so loss of signal was transient, lymph node frozen section was positive. So we went ahead and did a total thyroidectomy and central neck dissection. I think it was ipsilateral central neck dissection. And the plan for this patient, as I said before, was a total thyroidectomy to start off with, because she said she wanted it all out when we discussed the pros and cons of hemi and total. And because we have frozen section facilities, we did it. The final histology, as you can see on the screen, is papillary thyroid cancer, classical type. There's no biologically aggressive features at all. There's no vascular invasion. So one of the 7 lymph nodes in the central neck dissection specimen was positive and was a complete resection. So that's the histology you have. And the next question, I guess, would be, you're going to discuss this case in the MDT. So I presume I'm asking you, what would your MDT protocol be? What is the role of radioiodine ablation in this situation? Can I come back to you, Sid?
Yeah. So I think in this kind of scenario, we would discuss with the patient through the MDT, but certainly because there's an involved lymph node, we would consider offering radioactive iodine. I'm sure you're probably going to quote some papers or various things that may go against that, but yeah, we'll probably want to look at the pros and cons of both. But she is 60, she's quite young, and I think that's something to consider. So I think she's still relatively low risk. So if we were to do radioactive iodine, then you'd want to follow that with dynamic risk stratification down the line with regards to CSH suppression. But yeah.
Yeah, thank you, Sid. Any other opinions on the role for radioiodine ablation in this particular scenario?
I would like to differ with you, Dr. Sid. We at the institute, we do a radioiodine uptake and whole body scan and interpret along with a serum thyroglobulin value. So if uptake scan is less than 4% and a serum thyroglobulin value is less than 1, it falls under low risk category. So we would not advise even low dose ablation. We will not advise the patient radioiodine ablation if thyroglobulin values and radioiodine uptake scan are less than 4%.
Thank you. Thank you. I mean, I have to say that the uptake scan is no longer done in the UK. So we just go on the histology, thyroglobulin as well. And the results of the ESTIMABLE-2 trial have shown that radioiodine ablation in low-risk cancer does not add value. The UK ION trial results are going to come out soon, and I'm reliably informed that they're going to say that radioiodine is not required for good prognosis, low-risk thyroid cancer. So obviously there is still a bit of controversy. The only thing here is that one lymph node is positive, so we might think about that a little bit. but in Sheffield as well, we'd probably just leave this patient be without giving radioiodine ablation. But obviously, we'll discuss them with our oncology colleagues discussing the MDT.
Sorry,
My next question is... Sorry.
2 minutes warning, Professor Bach.
Oh, 2 minutes, right. Yeah, I'll wrap up. TSH suppression. I can see Professor Strachan here. Can I go straight to Professor Mark Strachan? You able to hear us, Mark? If you can comment on the value of TSH suppression in patients with, well, in this particular patient who has a PT2, P1A, R0, classic papillary thyroid cancer.
So thanks, Saba. So our guidelines that in the UK are that if the person is not getting radioactive iodine, then there's not a requirement for TSH suppression. So if it's been deemed by the MDT that they do not require radioactive iodine, then you wouldn't need to TSH suppress. If the patient had radioactive iodine, then they should have the TSH suppressed to below 0.1 until the dynamic risk stratification at 9 to 12 months.
Thank you very much, Mark. And if I could stay with you again for the duration of follow-up, assuming this patient has not had radioiodine, you're not TSH suppressing, in terms of follow-up, what would you do?
We would probably keep her under follow-up for 5 years.
Lovely. That's great. That's what I guess we will do as well. I think because of time constraints, I'll wrap this up. But thank you very much to people on the panel. Thanks also to our two additional panelists, Dr. Gonzalez and Professor Strachan. Thank you very much. Over to you, Jay.
Thank you.